Okay, this is Dr. Harris. At this time, it is 6:00 p.m. Eastern Standard Time. Looks like I do have one person on. Raven.
Hello.
I can't hear you.
Oh,
Here you go.
sorry, I'm driving. It might be okay.
It's okay. So this is a Q&A. You're driving, but I have a PowerPoint up with just some exam questions on there. And I am recording this so that, it'll stay up for the duration of the time. Do you have any questions or anything about the next exam?
Not right now.
Okay. Well, of course, if you do, be sure to email me before the exam starts, and I'll be happy to, answer any questions you might have.
Okay.
But on the slideshow here, some of them you might not be able to answer because you are driving and you can't see the screen that well. But what I did for this slideshow, trying to do something a little bit different, is I got a few things out of the study guide so that we could go over those. Of course, this is a match the cell from the left to the right. Because you're driving, I don't want to go there. We can't talk about that one. But for anybody that wants to look at this, at the recording, if we go through this and we want to match the cell on the right, the cell on the right to the function of it, then I can go through that and just, kind of give you a synopsis of what those cells would do. Okay, so we want to match the cell on the right to the action that it does on the left. And I'll make it self-explanatory. Okay.
Okay.
All right. Okay, so when we're looking at the cells, as far as, can you tell me a little bit about osteoid class? What do you know about that? Kind of going back to the basics. So the main, I don't want you to think too hard, you're driving. The main function of the osteoclasts are to secrete hyaluronate into the joint fluids. Okay. Again, do you happen to have the study guide?
I do have it at home.
Okay. Well, I'm going to review this and you can review the recording so you can look at it too. I'll just go through all the answer choices. So chondrocytes, they are cellular components as well. And the main function of those are to secrete collagen and other components of cartilage to the cells. Okay. Now, osteoblasts, in contrast to osteoclasts, simply help to lay down new bone. Okay, that's what their responsibility is. Let's see, type B synovial cells, they're responsible for secreting hyaluronate into the joint fluid. Looks like we have one more person added on. And then we have the osteocytes. So for exam purposes, I don't want to say that you don't need to know what all of these are, but osteoclasts, osteoblasts, and osteocytes are the three main functions or components of the cell. So you do want to really hone in on those three. That's covered, fairly well in your text as well. But the function of osteocytes is to help maintain bone by signaling the osteoblasts and the osteoclasts. Okay.
Okay.
All right, we're gonna move on over to the next activity. Sheena,
Yeah,
hey, this is Dr. Harris. How are you?
I'm good.
All right, so there's only one other person on right now. And what I told her was that we were going to be going through some slides and some questions. I'm trying to do things just a little different this go round. And then I'm still gonna, record this. You guys can review it, go through these questions. I'm gonna go ahead and tell you the answer. We can talk about it. And then I'll have my overall review posted for you guys too, probably tomorrow afternoon. Okay.
Okay.
Do you have any questions right now about the exam?
No, not right now.
Okay. All right. So let's see here. You have to be quiet, sir. Yes. Okay. So the next question or slide looks like we want to kind of discuss the pathophysiology of what's going on here. So I have a patient. His name is Jason. He's a 22-year-old soccer player, and he asks if my knee cartilage has no blood supply, how does it get its nourishment? Can either of you talk a little bit about blood supply to the knee for a soccer player? Okay. So I was saying I have a 22-year-old soccer player that wants to know about the if his knee cartilage doesn't have any blood supply, how is it getting its nourishment? Either one of you able to explain that from a pathophysiologic standpoint?
Cartilage doesn't have a blood supply source, correct?
Correct.
Like, I was really thinking this was a trick question.
No, it's not. So on your exam, it could be, a true false question. Okay. If we kind of worded it, a little differently.
Yeah.
That's the point of, going through something like this, because we know it doesn't have any blood supply. So let's say if we had a true false question, it may say you have a 22-year-old and, the nurse practitioner or the nurse practitioner would say that the patient needs more education because he says, my cartilage needs more blood supply for it to be nourished, and you would say true or false, something like that. Okay.
Okay.
All right. So our next patient is Miss Jackson. She's age 37, and she wants to know what's the difference between striated muscle and skeletal muscle.
They're the same.
Tell me what makes them similar.
So I can't explain that. I just, in my head, I'm thinking they're the same thing because that's what your skeletal muscle is. It's fibrous tissue that's elongated and kind of striped so that it allows for the movement.
Okay, perfect. Yeah, there's no difference in the in striated versus a skeletal muscle. So, you know, if they're looking at it, they might look at it under a microscope, you know, in pathophysiology or something like that, and they really wouldn't see a difference. Okay. So, next question. So you're beginning physical therapy on a patient, or you're sending the patient to physical therapy. You just happen to be there in the therapist's office. And the therapist, there's a student there, and he asks, you know, several questions. So he says, I was so busy memorizing the names of the little tubules that I lost the big picture. Why do muscle fibers need a sacrotubular system?
Yeah, I'm the last one. Y'all, I'll walk up. Leave the hall light on. Sorry.
It's okay.
I'm still at clinic today.
Oh, it's okay. So why do muscle fibers need sacrotubular or need a sacrotubular system? What's the purpose of a sacrotubular system? That's a hard word. It all has to do with the release of calcium, and calcium helps muscles to contract. So in order for, you know, the patient to start doing the physical therapy, you'll need that calcium release for the muscles to contract, and then it takes up stores and starts to store the calcium so that the muscles can relax. Okay. So that's what the sacrotubular system is in reference to. Remember, calcium, that would be your main component to that. Okay, intracellular calcium is good for muscle movement, either contraction or relaxation. All right, so you have Mr. Taylor, and he says, at the gym, I hear people talking about building lean body mass. What exactly do they mean? What is lean body mass?
That would be like your less fat, reducing your fat and increasing your muscle mass.
Yep, bulking up your muscles. That's right. That's absolutely right. All right. Looks like I had two of the same slides. Hang on. Okay, so we talked a little bit about, or learned a little bit about ankylosing spondylitis, fibromyalgia, gout, polymyositis, polymyositis, and osteomalacia. So in reference to these questions, this is, again, you want to match the pathophysiology to the disease process. Okay.
Okay.
All right. Okay. All right, so as far as the disease process, this disease process is an increased metabolic activity in bone causing abnormal and excessive bone remodeling that enlarges and softens bones. Any idea which disease process would that be? Osteomalacia, ankylosing spondylitis, fibromyalgia, Paget's disease, polymyositis, and gout.
Osteomalacia, isn't it?
Osteomalacia.
All right. It's actually Paget's.
Oh.
Okay. So it's Paget's disease. Let's see. This one is a syndrome involving high levels of uric acid in the body fluids, precipitating of uric acid crystals, and recurrent monoarticular arthritis. So you could have a certain type of arthritis, not just rheumatoid, but the main key point here is uric acid. Which one would that be?
Gout.
Yeah, very, very common. Okay, this one is an autoimmune inflammation of connective tissue and muscle fibers in pelvic and shoulder girdles mediated by T lymphocytes. Autoimmune, so we have osteomalacia, ankylosing spondylitis, fibromyalgia, and polymyositis.
Would it be polymyositis?
Yeah. Yeah, that's it. It's the autoimmune one. So this one is a metabolic disease of adults characterized by inadequate and delayed mineralization of osteoid immature bone.
That would be osteomalacia.
Yeah, that's correct. A chronic inflammatory joint disease characterized by stiffening and fusion of the spine and sacroiliac joint.
Ankylosing spondylitis.
Spondylitis.
Yeah, very, very common. I see it a lot in primary care. I do send those folks on over to either ortho. Some patients have to see the pain clinic, or some go to rheumatology. Okay. This last one is a chronic musculoskeletal syndrome characterized by widespread joint and muscle pain, fatigue, and increased sensitivity to touch at tender points.
Fibromyalgia.
Fibromyalgia.
All right. That's also very common. And what we're finding just out in the, clinical world here, there aren't many providers that take care of patients with fibromyalgia. We're doing a lot of it in primary care. And really, there's no true test or image for it for diagnosis purposes, but there is a tender point exam that you can do, and you really want to base your diagnosis on the patient's symptoms. And then of course, treatment. We know we're all in the opioid crisis, so that's not one of the treatment options we recommend. There are several things out there for it, just to help patients cope with, the pain that they have. All right. Okay, here is another, this one is about tumor characteristics, and this will be on your exam as well. So the answer choices are fibrosarcoma, osteosarcoma, giant cell tumor, chondrosarcoma, and rhabdomyosarcoma. Okay, take a look at the beginning part of these words to really figure out which disease process or type of tumor it would be. So we know fibro, we know osteo, think about bones, think about skeletal muscle. You want to think about collagen forming bone cells. You also want to think about which ones are collagen or cartilage forming malignant tumors. Okay, you want to know which one of these would be an aggressive form of a tumor versus, of course, the benign tumors. Okay. All right, so as far as a cartilage forming malignant tumor that does not ossify and typically seeds in surrounding tissue, which means it's spreading, which one of these would it most likely be? A fibrosarcoma, osteosarcoma, giant cell tumor, rhabdomyosarcoma, or a chondrosarcoma? Cartilage forming malignant tumor. So it's not benign, but it's more in the cartilage.
Is it the chondrosarcoma?
Yes. chondro and cartilage are the two key points there. Okay. Now, a benign solitary tumor originated from osteoclasts that is associated with pathologic fractures due to extensive bone resorption. Now, would that be a fibrosarcoma, a osteosarcoma, giant cell tumor, or a rhabdomyosarcoma?
Is that an osteosarcoma?
No,
Is it giant cell tumor?
yes, it's a giant cell tumor. What would be the difference between a giant cell tumor and an osteosarcoma? Or why wouldn't it be an
One-
osteosarcoma?
It's because it's benign.
Mhm. That's true. The giant cell tumors are usually benign. All right, so an aggressive malignant bone forming tumor that typically produces periosteal reaction. It's a malignant bone forming tumor.
Osteosarcoma.
Yeah, look at your root words. So osteosarcomas, those are the keys. Osteo is bone, but it's malignant. Okay. The benign solitary tumor would be the giant cell tumors because it has those root words in there, osteoclast. And you remember those are part of the bone cells. Okay. Let's see, another malignant tumor of the skeletal muscle that metastasizes rapidly.
Rhabdomyosarcoma.
Yeah. And then you have the collagen forming solitary malignant tumor that may be a secondary complication of radiation therapy.
Fibrosarcoma.
Yeah, fibrosarcoma. So when you're looking at these and you're trying to remember, let's say the rhabdomyosarcoma. Have you heard of rhabdomyolysis, or we talked about that in GI? So
Yes.
remember that has to do with muscle. Whenever I'm studying, I try to find key points that kind of, help me to remember those kind of things. So with the malignant tumor of the skeletal muscle, then that would help me remember that it has something to do with rhabdo. And then of course, if it's a sarcoma, it would be a tumor form. Okay.
Okay.
All right, so here we are into the digestive system. And with the digestive system, we have another few cells to the left that would match the function. I'm sorry, I said it backwards. The cells to the right that would match the functions on the left. All right. And what you really need to know for these, you want to know what the function of, the pancreas is. I tell patients that's your diabetic center because it's secreting what? What's going on in the pancreas to help it do what it needs to do for diabetic function?
It secretes insulin. That's the olive water on. How do you say that?
Right. And what about I know one question that may be on their exam is the Kupffer cells. Do you know what they are? Kupffer.
Those are in the liver.
And what's the function of it?
They remove the bacteria.
They move bacteria.
Right. From the hepatic sinusoids. Right. That's what I'm sorry, that's my grandbaby over here talking. Go talk with Nadia. Okay. All right. So let's move over to some digestive or disorders. So I want you to complete these sentences here. You have a person that has GERD, or gastroesophageal reflux disease. And when you're assessing this patient or getting a little bit of history from them, what would be some of the common side effects that they may say they have?
Heartburn.
Okay, what else?
The chronic cough.
Right. And we have to remember too with acid reflux, a lot of times, the patients will come in and say they have a chronic cough. They've, taken all of the over-the-counter cough medication. Sorry. They have taken a lot of over-the-counter medication, and the cough is just not getting any better. Many times, think about what's going on in that GI tract. Think about what's going on with the cough. Okay, think about what's going on with the cough. And typically I ask patients, do you have any acid reflux? And they may say, yes, they do. Or sometimes they even say they don't. But what we're finding is a lot of time the acid spills over into the lung cavities, and that's what's really causing them to cough. If they're coughing up some mucus, there may be a different color to it. It might be more frothy instead of, clear mucusy like a normal respiratory cough would be. Okay. So as far as a hiatal hernia, the most common type of hiatal hernia is a paraesophageal or a sliding hiatal hernia.
Is it sliding?
What's the difference between a sliding and a paraesophageal?
I'm not sure what the difference is.
Okay.
Remember.
Hang on, I'm gonna try to find a reference for you right quick.
Okay.
So best I can tell, I'm over here trying to look it up a little bit. The paraesophageal is the stomach and the esophagus stay in their normal location. Whereas with the sliding, they slide up into the chest.
Okay.
Kind of part of the stomach squeezes through the hiatus. Mm-hmm.
Okay. So when it's sliding, I want you to think of the answer of, I'm sorry, is sliding for the hiatal hernia. And this type of the sliding hiatal hernia is associated with reflux. So think about what's going on in the GI tract. You have the hiatal hernia, which is in the middle part of the belly. It's kind of raised up, and then you have a patient that has acid reflux. Whenever they swallow or whenever their belly gets full of acid and they're starting to regurgitate up the esophagus, that means that the hiatal hernia is starting to slide a little bit. Okay, so they swallow, and it's the same movement of your gut. Whenever you swallow, things kind of go up. Your diaphragm goes up. That hiatal hernia starts to slide there as well. Okay, so the key point for this is to know that hiatal hernia can be sliding, and that it is associated with GERD. Okay. Now, an acute obstruction high in the small intestine causes either vomiting or constipation first. Which one would it cause?
Vomiting.
Okay. And then an acute obstruction low in the small intestines causes vomiting or constipation first. Which one?
Constipation.
Right. And that's just common. Anytime it's obstructed, then you would know based on the patient's symptom if it's high or low. They got to up chuck it one way and down chuck it the other. Okay.
Okay.
Let's see. A patient with acute mesenteric ischemia. The damaged intestinal mucosa cannot produce enough mucus to protect itself from what? Acid or digestive enzymes?
Acid.
Okay. And then bacteria invade the healthy or the necrotic intestinal wall?
Healthy.
It's necrotic.
Necrotic. Okay.
Necrotic part. And then, which will eventually cause either malabsorption or peritonitis. Which one would it be?
Peritonitis.
Peritonitis.
And remember, it's peritonitis because this is already ischemic and it's bacteria there. So, peritonitis is an infectious disease process. All right, so when we talk about obesity and we talk about that visceral obesity and peripheral obesity, which one of these are associated with a greater risk of for metabolic syndrome, type 2 diabetes and cardiovascular complications? Would it be visceral? Would it be peripheral obesity?
Visceral.
Visceral.
And a lot of, when you're talking, you rarely talk about peripheral obesity. Most of the time, when we're working with our metabolic syndrome patients, it's most of the time visceral. It's all around the gut and the waistline. Okay. So visceral obesity is resistant to leptin. Okay. And then there's a decrease in either leptin or adiponectin insulin resistance in obesity. This part will not be on your exam. Just know about visceral obesity is associated greater risk for patients that have metabolic syndrome. Okay. All right, let's see some more digestive disorders. As far as diverticulitis and diverticulosis, you do need to know the difference between the two. What would be the difference between diverticulitis and diverticulosis?
Diverticulitis has an infection. Diverticulosis is just the little pockets.
Okay. And so if you had a patient that had diverticulosis, or let's say you worked in the GI lab and you were doing, performing colonoscopies with your partner, you were in there with your peer, which would you most likely find on a colonoscopy, the diverticulitis or a diverticulosis?
Diverticulitis.
What if they didn't have any symptoms at all?
diverticulosis.
Delosis.
Right, because remember, when they're going in for a colonoscopy, most of the time it's for a colonoscopy or colon screening, okay? So with diverticulitis, those pockets are really aggravated and inflamed, and that's when they need some antibiotics. With diverticulosis, that's kind of sort of watchful, wait and see, okay? It doesn't mean that there's inflammation, that the patient's having any symptoms at that point, okay? What kind of education would you tell the patient as far as diverticulitis? As far as eating habits?
Currently, I believe they still recommend avoiding like nuts and seeds and doing like a low residue diet.
Mhm. So you want to avoid anything that could get hung up in those little pockets in the diverticula. You know, corn is one of the ones too. So I've had a patient before, older lady. I think we had a storm or something, and you know, a lot of older people live by themselves. And she didn't really have a lot of food in the house, and so she ate popcorn for, you know, about 3 days. Whenever I saw her, you know, she's just said she complained that her stomach was hurting. So she was bloated. She did have a little gassy. You know, you have to rule out your appendicitis, your gallbladder, all that. She didn't have any nausea, vomiting, but she was just bloated and her stomach hurt. So, you know, I did my assessment, and I listened to her bowels, very hypoactive. I asked her about bowel movements, that kind of thing. She said kind of got a little bit of them, but not a lot, you know, as normal. But of course, she hadn't been eating a lot. And so I had asked her what was her diet like. You know, she able to, you know, have any fiber or anything in her diet. She said she's drinking plenty of water, but she said, Tara, over the last couple of days, I've been just eating and snacking on popcorn. It was so good. So I had to send her over for now thing is, her key thing is she just has stomach pain, but she didn't have a fever or chills or anything. So I sent her over for a an x-ray of her abdomen, and they just found some artifact, but they said it was a lot. So I sent her over for a CT, and that's where we found the diverticula. She had, you know, pockets of corn all everywhere down in the diverticula. So sent her over to the ER, and she was treated with some antibiotics, and she probably no longer wants to ever eat popcorn again. Because she didn't want to hurt so bad. So, you know, the key thing is make sure you're listening to your patients. A lot of times with diverticulitis, if they've had it one time, they know what it feels like to have it again. But make sure you go back over that their eating habits and what they eat in the last couple of days. That'll help you kind of figure out what's going on with them. Now, so patient, what kind of patient would you commonly see that would have dumping syndrome?
After surgery on their stomach.
Okay, so most of the time we see dumping syndrome in patients that have had a bariatric surgery. Can you tell me what happens during dumping syndrome?
From the places left over in the surgery, it causes, like when they eat sugar and stuff, it goes through the bowels much quicker than what it should, and the nutrients and stuff doesn't get absorbed.
Right. So they have like a rapid gastric emptying of all kinds of things, and it can cause them to be hypotensive, pale, diaphoretic, cramping, nausea, diarrhea, you know, tachycardia, a lot of different things. Now, as far as patients with IBS, what would be going on in the GI tract for a patient that has IBS? Would they only have diarrhea, or could they have constipation? Could it be a combination of the two?
Yeah, you have
Yes.
IBS constipation dominant, IBS diarrhea dominant, and then combination of either where they have bouts and go back and forth because of all the inflammation.
So in a patient with with IBS, what kind of education would you provide to them? Because, the patient comes in and they say, Sheena or Raven or Tyler, I've, had a lot of diarrhea one day, the next day I have constipation. Is it very typical for my stomach to hurt during this time? What would you say? So now they know they don't know what to eat. And they're trying to get some advice on, if they're having a lot of stomach pain, is that normal? What kind of foods they should eat, what kind of foods they should stay away from?
Yeah, they would have abdominal pain, and they
Okay.
should stay away from like fatty foods and stuff like that.
All right. What else, Sheena, do you think? Tell this patient.
If we're constipation dominant, I'm for sure going to tell them to increase like their fiber intake, fresh vegetables, fresh fruits, things we should all be eating anyways. And then of course, if they have diarrhea dominant, sometimes some lactose has a role in that. So, avoid anything that they see. I usually recommend like a food diary log for them to kind of see what triggers it and to avoid those products.
Exactly. Yeah. The main thing is try to make sure they're avoiding what causes the symptoms. And many times with constipation, if they hadn't gone for a couple days because of the motility in the belly, again, think about what they've eaten, but also make sure they're hydrating well. We do have some that have constipation and they're chronic laxative users. We got to make sure we're educating them that laxatives really aren't the best thing that you should use on a regular daily basis. Okay. Kind of just skipping through. Okay. As far as pediatric patho, you do want to know about neuroblastomas as well as retinoblastoma and Wilms tumor. Those are some common things that might show up on the exam. You also want to know about non-Hodgkin's. Okay. And how common is that in children? And then what, let's see, children that have cryptocortism are at risk for what type of cancer? And do you know what?
Testicular cancer.
Correct. All right, so this is an interesting kind of teach about the patho. It's related to a child that has diagnosis of cancer. So you have Mr. Towson's son has just received the diagnosis of cancer. And Mr. Towson says, oh no, my son has cancer. Now he's going to die. What do you tell the patient? This has to do with, patients having cancer, but it also has to do with educational moments regarding, how you would explain this different kind of, let's say it's a neuroblastoma. You would give the patient an explanation on what kind of cancer it is, and try to give them some more hope. So what would you tell Mr. Towson about his reaction to his son's new diagnosis?
I would start with explaining that cancer is not necessarily a death sentence, and go on to explain about the different types of treatments that potentially could be available, and depending on the type of cancer, maybe give them some statistics as far as survival rates.
Okay. Sheena, what do you think? Was that Sheena?
That was me that just responded.
Okay, sorry. I was trying to look at the little microphone to see who's speaking. Raven, what are your thoughts?
I would go along the same lines, and then I'd say more about like most of the childhood cancers have like up to 80% survival rate.
Okay. And Tyler, I know you're on here. Not sure. If you
Yeah,
can
hello. I
contribute.
guess I could talk to him about treatment options and kind of what's next to give him a glimmer of hope and that death is not the next thing that's going to happen.
Okay, great. All right, and from a patho standpoint, if you saw this question on your exam, it may point out, one of the most common childhood cancers. And, the main thing is you want to talk to them about the cellular growth. Is it a rapid growing cancer? Is it a slow growing? And as someone mentioned, we have a lot of treatments now. Many times patients want to know what's the most common, and is my child's cancer the most common form, and how much of it do you know about? So that's the key point from that. If you saw it on an exam, how common is this specific cancer? And the cancers that may be on the exam, again, would be neuroblastoma, Wilms tumor, retinoblastoma, and testicular cancer. Okay. All right. So we talked a little bit about digestive disorders. You do need to know about some of the pediatric digestive disorders, such as pyloric stenosis. We have a lot of children that are lactose intolerant. Hirschsprung's disease is a very common childhood digestive disorder, as well as biliary atresia. Okay. Portal hypertension is common too. I've not ever experienced or seen a child with portal hypertension, but some of the others I mentioned I have. So let's do some, I'm gonna call out some conditions or the signs and symptoms of the condition, and you just try to tell me which condition it would be, okay? So you have a patient, a pediatric patient that you're examining, and you notice that they have an enlarged spleen, some bloody emesis or melena, and ascites. Which pediatric condition might that be related to? Portal hypertension, biliary atresia, Hirschsprung's, pyloric stenosis, or lactose intolerant.
Would it be portal hypertension?
Let's see. All right, so this particular patient, yes, would be portal hypertension. And the main thing with portal hypertension is that it has to do with the spleen, and most of those patients have ascites. And that's very common in adults as well. So you have a pediatric patient that has chronic constipation, poor weight gain, a progressive abdominal distension, and may develop small volume diarrhea. Which condition would that be? Biliary atresia, Hirschsprung's, pyloric stenosis, or lactose intolerance?
Hirschsprung disease.
Very common in Hirschsprung's. All right, so you have an infant who previously has fed well and gained weight, but he develops repeated projectile vomiting and wants to eat again soon after each vomiting episode. What condition would this patient have?
Caloric stenosis.
Pyloric stenosis.
Or What else could it be?
Lactose intolerant.
Right. He could very well be lactose intolerant. Okay. Now, you have a pediatric patient with abdominal pain, bloating, gassy, and diarrhea after drinking milk. Which one would that be?
Lactose intolerant.
Lactose intolerance.
Yeah, that's really lactose intolerant. And lastly, you have a patient that's jaundice, enlarged liver, clay-colored stools, and failure to gain weight. So what condition would that patient have?
Biliary atresia.
Right. We only have just a few more minutes, so I'm gonna just go through the slides a little bit and give you a little bit more detail on what you might see on the exam and some things you want to study for. So as far as skin, you want to make sure that you are aware of different types of infections that can be considered bacterial, viral versus fungal. So if you had a patient that had tinea capitis, or tinea corpus, what would that be considered? A bacterial infection or fungal infection or viral? Herpes zoster or chickenpox or measles. So just be aware of what disease process would be considered a bacterial versus viral versus fungus. Okay. As far as pediatric skin disorders, impetigo is one of the most common pediatric skin disorders. You do want to know what the characteristics of that impetigo is. Okay. Typically, you have a child that has maybe a bug bite. Children don't wash their hands that well, so they start scratching it. It gets infected. They get that honey crusted lesion on there, and that would be considered, an impetigus lesion. And then, we would treat it accordingly. Okay. Let's see. You also want to know a little bit about scabies. Scabies infection, and it's very common in children, what it would look like. As far as, many times symptom-wise, patients may come in with blisters in the webbings of their feet or their hands. It's very itchy, and it gets worse at night. So you want to know about the physical exam, characteristics you might see. And if you needed to, would you perform any labs such as scrapings of the blisters or anything like that? Okay. And that's all I have for you tonight. But again, this is recorded. We just went over a few things. Tyler, I know you came in a little late, but I grabbed these questions from your study guide. Since this is recorded, once it uploads into my computer, I'll send it out to everyone and put it on the in your announcements, and you can go back through. You can see all of the questions. And then, if you don't have the study guide, but you need some clarity regarding an answer, I'm happy to help you with that. Tomorrow evening and tomorrow night, I will be posting my general overview for exam purposes, and I'll post that into the announcements as well. Does anyone have any questions?
No.
No, I don't have any questions.
Okay. All right. So you guys do well on your exam. I know you will. If you have questions prior to, just let me know. Just be mindful that exam starts on Tuesday a.m. and it ends on Friday at 8 a.m. Okay.
All right.
All right.
All right. Thank you guys. Have a good rest of the afternoon
You too.
or evening.
All right. Thank you. You too.
Thanks. Bye.